let's go a little bit further. The acute behavioral unit, 4 to 6 bed locked wandering unit, medically stable, and if you get unstable, you can go right back to the acute geriatric unit or go to the general medical ward, because now you got an out. You got a way of moving people back and forth within in the hospital to meet their needs on the various units. Usually off all psychotropics in 72 hours. That is absolutely amazing. Okay? The one thing that happens in our hospital is that we've got no place to place the patients. We have to use chemical restraint sometimes. We have no choice. The worst case that I can relate was when I was doing rehab about 4 or 5 years ago. We did a case conference at the Miller Center. And the social worker, God bless her, said, now, this lady comes down with delirium, and she had hip fracture and a few other things, the sepsis and whatnot. How many moves do you think she had in acute care before she got to the Miller Center? Take a guess. I'll start at 5. Do I hear 10? 10? Do I hear 15? Do I hear 20? Do I hear 25? Would you believe 26? Okay, if I took you and you were sick and I moved you 26 times in a hospital, I think you would be confused. Okay, let's go on now. Now you'll see up here I put a brown slide in. And that was one that I couldn't really fit anywhere else. In Australia, they've done something really neat. They've realized that orthopedics is becoming geriatrics. So they said, well, why the hell do we have orthopedics? Let's call it orthogeriatrics, and let's have the geriatricians and orthopedics work together. So that when the patient comes in, their pre-hospital care is done by the geriatrician who's with them. So the geriatrician sees the patient pre-op, patient gets operated, 48 hours the surgeon does his thing on the ward, and then 48 hours there's a handover to the geriatrician to follow up post-op care and send them home and coordinate care. Beautifully done. And I saw something in that hospital I haven't seen anywhere else. I had a patient that came in who had a pathological fracture. The surgeon the geriatrician is consulted, says this patient doesn't need to see the surgeon. This patient is palliative. Let's make this patient comfortable in her final hours. And that patient died with dignity and respect. And I thought that was really something, because they are very, very patient-centered, very patient. And we are patient-centered too, but the factory forces us to make decisions that are not in the best interest of seniors often, because we have the factory designed for one purpose and one system. And we got to take a comprehensive approach. And you say, well, how are we going to get all these people? Well, the people are in there now, but we have to rethink how we do the job in the factory. So, the orthogeriatric ward. Team rounds are weekly. We could do this here. We have a physiatrist in Newfoundland, and the physiatrist has the same philosophy of rehab as a geriatrician. And I'm wondering, if we were to attach the physiatrist to our orthopedic floor, could we do the same thing? Right? Now, what is this coming down here? You see this new green one? This is where Dr. Kaplan has done some amazing work. He took the challenge that, why do we put people in hospital anyway? If hospitals are dangerous for old people, let's get them out of hospital. So he did this study. He took delirious patients, and he said, I'll take a cohort of 100 people, and I'll take one group, and he did this as double-blind, randomized, and one group goes to the usual care, and one group, after delirium is treated medically for the first 5 to 7 days in hospital, I'll send them home with the same supports they got in hospital. And what do you think he found? If you have a confused mind and you're sick and confused, and I send you home and you have a familiar environment and you have good people around you that you know who are going to make sure you're sleeping properly and that you got food and nutrition, should it surprise you that you do better? But what will surprise you is how much better you do. You do about 50% to 100% better. In other words, their lengths of stay in rehab, if you take the crowd that went home versus the ones that stayed in hospital, are halved. The average length of time for the people that were delirious in hospital was 40 days. And for the people who went home in the same cohort, double-blind, randomized, controlled, 20 days. That is a tremendous saving. In fact, Dr. Kaplan has saved so much money by developing his post-op, his post-acute care service, which goes for 6 weeks, that he now is taking people from the emergency department directly 10% of the time and putting them in the PACs. He takes a substantial number off the acute unit and puts them directly to PACs. And there's 35 new cases every week going here. All their anticoagulation is done through PACs. There's nobody admitted to hospital unless you have oxygenation problems. Okay? It's the only ones get in hospital. He does all his chronic obstructive lung disease through that. Post-op wound care and all this sort of stuff for complicated surgical ones that need ongoing monitoring, who are elderly, frail people, they come off the ortho unit and come directly down here. So what all of a sudden you got is flexibility in the system, because you see there's relief valves here for here and here, relief valves here. This thing here, when it's down, can take pressure off the inpatient service. When this thing is on bus, the inpatient service can pick up. So it's a two-way street. But you say, well, how in the hell? You know, in Australia, he got a big density of population around the hospital, right? So you can't do that in Newfoundland. Because, you know, it's fine for you, Roger, to say, you know, 65,000 visits and you got 2 million people in a 10-kilometer radius, right? Well, wrong. In St. John's, 85% of people who go to the health sciences are within 10 kilometers of the health sciences. Okay? He has 14 nurses, and I'll just go through the numbers. I think I got it written here. 14 nurses, 2 OTs, 1 social worker, 2 physios, and 1 MD. This is completely paid for out of savings in the acute care system, and he's doing it on 75-cent dollars. Okay? And these are people that are looked after in their homes. Their previous level of home support is not interfered with. These are people who require additional acute care support, but they're getting it in their homes. And these are the diagnoses he's doing now. Acute infections, COPD, CHF, DVT, thromboembolic, TIA, ischemic CVA, atrial fibrillation, falls with mobility issues. And look who he's got on his team. 2 physios on a team for 35 patients. We have 2 physios looking after 1,100 people in our home care district. This is a disgrace. We have to get the manpower to do the job. We can't do the job without the manpower. So we've got to change how we think. The factory, in order to work efficiently, and in order for us to get the beds moving, has to have the support services in the community. And Hasnain will probably be linking into that in his discussion. You've got to get back to the family doctor. If you're going to maintain sick people after they get through their acute episode, tie the family doctor in. It's no longer acceptable for us not to get discharge summaries promptly. It's no longer acceptable for a family doctor to be getting a call from the home care nurse or the social worker informing them that the patient has gone home. These are sick patients. These deserve doctor-to-doctor discussions. In this clinic here, he has a physician who looks after these people. They discuss rounds Monday morning. They target those 35 patients and look after them. They are followed. Okay. So then you see, so the acute unit, in order for it to function, has to have outputs. 70% go this way, 10% go this way, a bunch go this way, a bunch go this way. And then you've got the nursing home, personal care home transfer, and you got rehab. And rehab goes back and forth to the general medical ward. This can work. We have all the pieces in place. It will not cost us another red penny. So why don't we do it? Why don't we do it? I've presented this to several members of the corporate team. I've been told it has been shelved. Okay. Reflections down under. No patients seen on a stretcher in either emergency room over a 3-week period. Now, what do you think of that? Can you remember a day, for those of you people who work in the emergency department, that you haven't had an elderly patient in a stretcher in the last week? Show me your hands if you had. Have you had a day in the last week that you haven't had an elderly patient in a stretcher? Okay, nobody. I think, put the camera down, show that, please. This is 3 weeks in 3 emergency departments with 65,000 visits a year each. Okay, it's just absolutely amazing. Now, private hospital add no benefit to the ER. Now, what's he talking about, private hospitals? In Australia, they have the private system working with the public system. The emergency physician said this is absolutely no benefit to them. It makes it worse, in fact, because you suck the good doctors out of the system who are beat out and they want to have a controlled lifestyle from 9 to 5. Private care erodes MD availability in the public sector. In Canada, we're doing some things right. And for seniors care, I'm going to echo this term. Our public health system is the right way to go, but we've got to put the fuel into it.